Hello, I'm Alice Bremner-Smith. I'm a consultant hand and wrist surgeon based at Chelsea and Westminster Hospital in London, and I treat all aspects of hand and wrist pathology, including traumatic injuries and elective conditions. I'm going to talk about the wrist in tennis players, particularly in higher level tennis players. And it is quite a significant problem in tennis, and it accounts for about 11% of significant injuries in men and about 16% in women. You do get general injuries, falls, etc., but most of the problems occur from the chronic use. As we were saying, the players play a great deal, and most of the pain is on the ulnar side of the wrist, and ECU problems are by far the biggest problem. So I'm actually going to focus, this talk is primarily going to be focused on that. And there are some precipitant factors that have been identified, primarily players that use a big range of motion run into more problems. Interestingly, the elite players, a lot of them, some of them can play with a restricted range of motion very well, and it tends to be the more less experienced players that use the bigger range of motion. And other factors count, like the time when they hit the ball. If you hit the ball late, you get a higher loading impact. So there can be modifications made to the way people play. Obviously these days, tennis has a lot of talk about topspin. It's become a big issue, and it causes quite a lot of issues with people's wrists, especially the double-handed backhand, which is responsible for a lot of problems. Can be in either hand. And for example, in this player, you can see this is a very vulnerable position for the wrist. It's flexed, it's ulnar deviated, and it's in full pronation, and he's about to whip it round into supination, and it puts a lot of stress on the ulnar side. String tension tends to be high to get a powerful return. Grip styles vary. This is a Western style where they use a fully supinated wrist and then they whip it round again into full pronation to get the topspin. That's associated with more problems. And often the wrist is in ulnar deviation when it hits the ball, so it's got a high stress on that ulnar side. There are various things on the ulnar side of the wrist that can cause trouble, as well as ECU. There's the TFCC, there's the lunotriquetral ligament, there's the piezotriquetral ligament, which has actually been chopped off in this section. And you can get fractures and other injuries, but I'm not really going to focus on those because they're actually rarer. It's primarily ECU that we're looking at, and there are various things that can happen to it. You can get a synovitis, you can have a tendinopathy, you can get instability, and you can get rupture, or you can get a combination of these. And again, you can see, for example, here, this is ECU here. You can see how much stress it's put under and why it starts to suffer. So ECU is a long muscle located on the ulnar aspect of the forearm. It arises in the lateral epicondyle and inserts down here into the base of the fifth metacarpal. And its action varies depending on the position of the forearm. One of the key things about it is after it leaves the forearm, it goes through a fibro-osseous tunnel here, which is basically based in a bony groove on the back of the ulnar. The roof is made by the retinaculum, which stops it bowstringing, but underneath that there's a sub-sheath which attaches it to the ulnar. And that's the most important stabilizing factor. And this sheath means that ECU moves less freely, it's fixed compared to the other tendons, and so it comes under a lot more stress in pronation and supination. It varies its action. In pronation it's slightly volar, it's situated away from EDM, and it doesn't contribute a lot to extension. In supination it moves dorsally and closer to EDM, and then it runs through a 30-degree angle at the wrist before it inserts, and that's when it's under the greatest tension, and that's when most of the problems seem to occur. So initially, the usual early sign of a problem is tendonitis or tenosynovitis, and we all know what that is. It's an inflammation, usually in the sheath primarily, with increased fluid. And examination can be fairly vague. It's normally just a pain on the ulnar side of the wrist. You can get a bit of tenderness to palpation. Classically, resisted extension in ulnar deviation will reproduce that pain. Moving on from tendinitis, sort of moving a step forward, you can start to get tendinopathy. And this is slightly different. This is where the tendon starts to fail to adapt to the stresses that are being put on it. And you can start to get actual disintegration within the tendon collagen tissues. And it's described as going through certain stages, although it's basically a gradual spectrum. And it can start as a reactive tendinopathy, where the tendon is basically intact, minimal change, but it slightly thickens and it's slightly stiffer. Moving on to disrepair, where the structure starts to break down and you can get increased vascularity. And finally, a degenerative tendinopathy, which is commoner in older athletes, where the collagen becomes more disorganized, the matrix starts to fall into disarray, and you can start to get partial tears and splitting in the tendon. The symptoms of tendinopathy are similar to tendinitis, basically. The story is a gradual onset of pain, typically on the ulnar side of the wrist, sometimes a dull ache with a much worse pain on certain movements. Often tennis players can continue to play tennis with these symptoms. It often hurts primarily when they do the first strokes in the warm-up, and then they find they can adapt to it and start playing. Clinically, you can get a slight swelling of the sheath and some pain on palpation. And there is a test for tendinosis, which is if you take the patient's arm and put them in 90 degrees at the elbow, supinate and extend the fingers, then you palpate the thumb and put your other end of your hand, side of your hand, obviously it'd be the other way around in a patient, on the ECU and adduct the thumb, then the ECU contracts. And if that's associated with pain, that's supposed to be pathognomonic for ECU tendinosis. Another problem that's particularly relevant for tennis players is instability of ECU. And there's a massive spectrum. It can range from a very minor instability to frank dislocation. And it results from rupture or disruption of the sheath. Typically starts with an acute traumatic event, but rarely can be just produced by repetitive use. And it's particularly vulnerable, as I said, in the double-handed backhand. And what's quite interesting, if you look at these two players, so this is Djokovic up here, who does a double-handed backhand, and this wrist again is ulnar deviated, flexed, and about to go pronation into supination. Whereas Federer, if you watch him play, has got a fantastic wrist position. It's almost in neutral when it hits the ball, and it's very strong. He's got a really good technique for longevity. The actual anatomy of the ECU instability, I'm not going to go into in great detail, but basically, as I say, there's two components. There's the retinaculum that goes over the top. That can disrupt and the tendon can completely come out. But more commonly, there's a subsheath underneath that ruptures, and basically it can rupture on the ulnar side or the radial side, or it can detach and take the periosteum out of the distal ulna. The symptoms of this, there's usually an acute episode which is described as a pop or a snap or a sudden pain, and the player has to stop playing. Sometimes only for a few minutes, sometimes for a few days, and then sometimes they find they can resume playing but with a slightly different stroke, usually putting on less topspin and using a flatter stroke action. Also described as a rebound pain. When they've hit, they get pain around the ulnar styloid. That's another symptom that's described. The odd thing about instability is some people can have apparent instability which is actually painless and asymptomatic. So it's, the difficulty sometimes is differentiating between those two. So with instability, it can sometimes be painful, sometimes not so. You can see the subluxing snap of the tendon as ECU contracts in certain positions of the wrist. And again, one of the ways to do this is to hold the wrist in this position, ulnar deviation and flexion, and then get the patient to try and supinate against you. And that will usually cause it to pop out if it's going to be unstable. Often the signs are more subtle, and again, you get tenderness, some swelling on the dorso-ulnar aspect of the wrist. And before going on to imaging, there's another condition that can happen, which is actual rupture of ECU. This is not common, this is rare, and may follow a tendinopathy. Interestingly, in the cases that are described, it is rare, and it can follow that there is a possible association with steroid injections in tendinopathic ECU. Classically, the players say they can do normal daily activities fine with a ruptured ECU, but they can't do their power stroke, they can't do their double-handed backhand. So imaging is important to differentiate between the different conditions, and ultrasound is probably the most useful imaging modality. And the great thing about ultrasound is it's quick, you can visualize inflammation at the same time, you can compare the other side, and you can do dynamic testing for instability and actually see what's happening. And also you can ask the radiologist to inject steroid at the same time, if that's helpful. And what you might see in tendinitis, you tend to see increased fluid in the sheath that's compressible, and the tendon may look normal. With tendinopathy, you may see thickening initially and then low echo areas as the tendon's substance starts to degenerate, and sometimes then clefts or splits further on. And if it's ruptured, then you've got an empty sheath. Initially you may get a hematoma, and later on you get atrophy of the muscle as well. For instability, the ultrasound can be tested in the same way as the clinical exam, and you can sometimes see that instability with ultrasound. But as I say, it's important to differentiate from a normal degree of instability, and it's generally considered if it comes out more than 50%, and particularly if it fails to go back into the groove when you pronate, then that's probably symptomatic and significant instability. MRI is a helpful adjunct to ultrasound, and one of the useful things about MRI with instability is you may be able to locate the site and the area on the subsheath where the instability has occurred, and you can actually also use it for monitoring recovery in that way. So I think ultrasound is the most useful, but MRI has a role as well. So treatment for these, well, tenosynovitis or tendinitis, most of us know, can be treated with rest, it can be treated with anti-inflammatories, splintage, and maybe some guided injections if required. Tendinopathy is similar. Activity modification, modifying technique, which applies to all of these conditions. And again, rest, splintage. Some advocate long arm casts in pronation. There are different modalities of splintage depending on the severity of the case and how recalcitrant it is. It's thought anti-inflammatories may be helpful. In the early stages it may be reversible by this process, but later on less likely to be reversible. And ultimately there is little more that can be done other than considering a guided steroid injection, but obviously being wary if you have a tendinopathy of the status of the tendon, and being wary about the risk of causing a rupture. You can inject local anaesthetic first to dilate the sheath, which can be helpful diagnostically and also allow placement of the steroid. The other option is to surgically decompress the compartment by going between the 5th and 6th compartments, so that you need to maintain the stability of the ECU whilst giving it more room, so that it's not so stressed on movement. And for ECU instability, there's a range of treatments. If you have an early acute injury, this can be treated non-operatively. It doesn't need to be surgically reconstructed, and most cases aren't. And it can be treated for a variable amount of time depending on how well it heals. If you look at the literature cases that are described, it may be up to 4 months, which is a long time for elite athletes to be out of play. So often what you can do is take it out each month, image it and stress it and see if it's healing. And as soon as it appears to be returning to stability, then obviously you can take things a step forward. You can surgically reconstruct these, and you can either do it, it's described as non-anatomically, using a little bit of ECU, which this little picture is just sort of demonstrating here. You literally just use ECU to form a new sort of sheath around it. Or you can anatomically reattach it if the subsheath has come away to the distal ulna. And for ECU rupture, obviously you can't repair a ruptured tendon, but you can use another tendon, for example palmaris longus, to reconstruct that. But that's a longer procedure. But if players want to get back to high-level tennis, it is felt to be very significant if that tendon is ruptured as regards their level of play, so they may wish to pursue that. I haven't gone into tennis elbow because I felt that's elbow, not wrist, so that's a talk for another time. I've talked a lot about ECU, but there are other, actually de Quervain's tendinitis is probably the commonest tendinitis in general tennis players in the wrist rather than elite players. FCU tendinitis is also very common on the ulnar side, and they're all treated in much the same manner as the ECU conditions, but not associated with instability. Thank you.